Hello and welcome to ResearchPod. Thanks for listening and joining us today. In this episode, we're examining the effects of anesthesia on blood pressure. Critically, how can anaesthetists and surgeons better monitor the blood pressure of any patient under general anesthesia to prevent hypotension and the associated risks a drop in blood pressure poses to the heart, kidneys, and brain? Professor Anita Neeleshwar at the University of Manipal, India, has investigated the value of measuring the diameter of a vein under the collarbone in predicting hypotension during anesthesia. This could be an essential factor in a challenging surgical environment where, to date, there is no easy-to-use, accurate way of predicting these potentially fatal complications. General anesthesia is a controlled, sleep-like state that keeps patients unconscious and pain-free during surgical procedures. This state of unconsciousness is achieved and sustained with the use of special medicines called anesthetics. During the procedure, the doctor in charge, the anaesthetist, monitors the heart rate, blood pressure, breathing, and other vital signs to make sure they are steady and that the patient remains safely asleep. However, as with any medical intervention, general anesthesia can have side effects. One of the most common side effects is low blood pressure, or hypotension. Blood pressure can drop during anesthesia for various reasons, often as an effect of the anesthetics themselves, but sometimes because of the patient's extensive fluid or blood loss before surgery, alternatively known as hypovolemic shock, and more rarely because of sepsis or an allergic reaction to the medicines. Extended or very low blood pressure can affect the oxygen supply to vital organs such as the brain, kidneys, and heart, and damage them, which in some cases can even lead to death. The severe risks involved make monitoring the patient's blood pressure before, during, and after general anesthesia a critical task. Predicting which patients are more likely to develop hypotension can help the clinicians be more vigilant and act more timely to prevent adverse events. To assess these patients before their induction to general anesthesia, anaesthetists take their history and perform a physical examination which can reveal signs of dehydration, such as dizziness, increased heart rate, and low baseline blood pressure. Sometimes, especially for complex cases or unwell patients, more sophisticated methods need to be used prior to anesthesia, such as echocardiography. Echocardiography is an ultrasound scan of the heart to measure the volume of its chambers as an estimate of the total volume of the circulating blood in the body. Beside the patient's basic assessment process, there are also dynamic methods to identify issues with blood pressure during general anesthesia, such as measuring the pulse pressure, the heart stroke volume, and the blood flow inside the big vessels near the heart. These measurements are very accurate and helpful, but are also invasive and not without their own side effects. Veins are the blood vessels through which blood returns from tissues to the heart. If the volume of circulating blood is low or unevenly distributed, as happens when a patient has low blood pressure, the veins can be empty and appear more collapsed than normal. Previous studies have established that measuring the minimum and maximum diameters of the body's large veins, such as the inferior vena cava, the vein that returns the blood from the torso and lower body to the heart, can reliably predict whether the patient's low blood pressure will rise after giving them intravenous fluids. The changes of the diameter of the inferior vena cava with breathing or after raising patients' legs can also provide important information that can help predict hypotension early. Some researchers decide to include smaller vein diameters, such as the subclavian vein, a major vein that runs near the collarbone, as potential hypotension prediction tools. Unfortunately, the results of such studies have so far been controversial, with some of the researchers concluding that the subclavian vein's diameters are a sensitive predictor of hypotension, and others that it's not. Measuring the diameter of the subclavian vein instead of the inferior vena cava before and during general anesthesia would be a helpful tool, especially because it is easier to access, and also because most anaesthetists already have the relevant technical skills. This is why Professor Anita Neeleshwar at the University of Manipal, India, conducted a study to test whether the subclavian vein diameter measurements can accurately predict hypotension and fluid responsiveness during general anesthesia. Professor Neeleshwar is head of anesthesiology at the University of Manipal, with more than 30 years of experience in intensive care, respiratory care, trauma care, and research. She has also served as chief editor of the Indian Journal of Respiratory Care since its inception in 2012. The University of Manipal research team included 80 patients in their study. Before induction to anesthesia, they measured the minimum and maximum diameters of the subclavian vein using ultrasound scans in 3 different states: spontaneous breathing, deep breathing, and with raised legs. After induction of general anesthesia, 51 out of the 80 patients developed hypotension, while 29 did not. Unfortunately, the team did not find any significant differences in the baseline subclavian vein diameters between the 2 groups in any of the 3 different states. Surprisingly, the group of patients that developed hypotension also had higher initial mean blood pressure, which means that after the induction of anesthetic, they demonstrated a bigger drop in their blood pressure compared to those who did not develop hypotension. It's also worth noting that no link was found between the drop in blood pressure and the subclavian vein collapsibility during normal breathing, deep breathing, or passive leg raising. Despite the limitations of their study, for example using the vague and subjective variable deep breathing, the researchers conclude that monitoring the diameter of the subclavian vein with and without raising the patient's legs cannot be used as a hypotension prediction tool during general anesthesia. A reason for this could be that the subclavian vein is potentially less collapsible than bigger veins, and therefore the smaller range of its diameter with breathing is practically undetectable. That's all for now. Links to Professor Neeleshwar's research can be found in the show notes for this episode, and, as ever, don't forget to subscribe to ResearchPod for more of the latest science from around the globe. See you soon.